All right, let's just dive right into this. Welcome to a brand new explainer where we're tackling one of the absolute highest stakes scenarios in adult medicine, suspected acute coronary syndrome, or ACS. I really want you to picture a literal ticking clock here, because from the exact second that patient rolls through your doors, every single decision you make, every test, every med, it's all firmly anchored to that relentless passage of time. In this explainer, we're going to map out the modernized 2025 guidelines and see exactly how tightening up our approach literally saves lives and, well, heart muscle.
Here's the quick clinical pathway we'll be following today. 1. The first 10 minutes. 2. The crucial branch point. 3. Beating the reperfusion clock. 4. The modernized MONA-B protocol. And finally, 5. Connect with the academy. Let's get to it.
Section 1. The first 10 minutes, when absolutely every second counts.
Now, the number 10 here is huge. The entire triage tree, basically everything we're about to cover, depends entirely on acquiring and interpreting a 12-lead ECG within a strict 10-minute window from arrival. You know, if the first one's non-diagnostic, sure, you do serial ECGs. But getting that initial read in under 10 minutes, absolutely non-negotiable.
And while you're getting that ECG, you've got to multitask. Within that same initial window, you need to initiate 2 other crucial steps. Step 2 is drawing serial troponins, specifically high-sensitivity troponin, every 1 to 3 hours. We're looking for anything creeping above that 99th percentile, which tells us, yep, there's myocardial injury. Step 3, risk stratification using TIMI or GRACE scores. If your patient ends up in the non-ST elevation category, calculating these scores right off the bat helps you decide just how fast they need to be rushed to the cath lab for an early invasive strategy.
Moving on to Section 2, the crucial branch point, the ECG question that dictates everything.
So this is where we hit a massive fork in the road. You're staring at that ECG, looking for ST elevation. If it's there, meaning it's greater than 1 millimeter in at least 2 contiguous leads, boom, you are going down the STEMI pathway. That means we're dealing with a total occlusion of the artery. But if there's no ST elevation, you're looking at the NST ACS pathway, which usually points to a partial occlusion. This one split totally changes your entire operational timeline.
To actually lock in that final diagnosis, though, we have to combine the ECG with our troponin result. Like we said, ST elevation splits the major branches right at the top. But if there is no ST elevation, it's the troponin that tells us the rest of the story. A positive troponin, that means it's an NSTEMI, there's definite heart muscle injury. A negative troponin, that means it's unstable angina. So you can't just use one or the other. Neither the ECG nor the troponin alone makes the diagnosis. You've got to read them together.
All right, Section 3. Beating the reperfusion clock, time is heart muscle.
Look, a STEMI is an automatic, all-hands-on-deck call for immediate reperfusion. The only real decision left is which method to use and how fast you can do it. So let's walk through this timeline. Arrival is minute 0. At 10 minutes, you've got your ECG read. From there, depending on your facility's capabilities, you have 2 absolute rock-solid targets.
First step, if you'll add a PCI-capable center, primary PCI within 90 minutes of first medical contact is the gold standard. That is exactly what you want. Getting that balloon inflated and popping that artery open inside of an hour and a half is quite literally what saves lives here.
But what if you're at a smaller facility where PCI just cannot realistically happen within 120 minutes? Well, that's when you fall back to fibrinolysis. But pay attention to this time frame. You have a super strict door-to-needle limit of 30 minutes or less to push those lytics. After that, you transfer them to a PCI center.
Okay, pause. Please pay super close attention to this next point, because I really can't emphasize it enough. Never use fibrinolysis for isolated ST depression. Seriously, no way. Fibrinolysis is for ST elevation only. This right here is the classic trap. A patient comes in, they've got a positive troponin and ST depression. It's so easy to panic and think, oh, they need lytics. They do not. That patient has NSTEMI ACS. And in that specific scenario, lytics are absolutely contraindicated. Please don't fall for that trap.
Section 4. The modernized MONA-B protocol. Retiring the old dogma.
So for decades, right, we were all taught to just blindly give everyone MONA, morphine, oxygen, nitro, aspirin. But looking at the 2025 evidence, actually, aspirin is the only true, unambiguous, give-it-to-everyone hero left in the protocol. It is a Class 1, mortality-reducing intervention. You absolutely must give 162 to 325 milligrams. It has to be non-enteric-coated, and they need to chew and swallow it immediately the second they present.
But what about the rest of MONA-B? Well, the latest evidence has seriously trimmed it down with some heavy caveats. Take morphine, for example. We really only use it now if pain persists despite max anti-ischemics, mostly because it actually delays the absorption of P2Y12 inhibitors, plus there's a pretty controversial mortality signal there. Nitroglycerin? You've got to ask about PDE5 inhibitors, like sildenafil first, and you must check for a right ventricular infarct, or you could cause a massive, dangerous pressure drop. And beta blockers. Oral is fine within 24 hours if they're stable, but avoid IV beta blockers entirely if acute heart failure or hemodynamic instability is in the picture. And then there's oxygen. Guys, this is a massive paradigm shift. Routine O2 in the non-hypoxic patient is harmful. I'm going to say that one more time. Harmful. We just don't slap oxygen on everyone who walks through the door anymore. Routine oxygen requires a saturation below 90% or clear, obvious respiratory distress to actually justify using it.
Let's take all of this modernized data and translate it into a really practical bedside checklist that you can start using on rounds today. Step 1. Confirm, out loud, that the ECG was done and read within 10 minutes. Step 2. Ensure non-enteric-coated aspirin was chewed. Step 3. Actively screen for PDE5 inhibitors and heart failure before you even think about throwing nitro or beta blockers at the patient. And Step 4. Verbalize that reperfusion clock aloud to your team. Literally ask, is primary PCI achievable in 90 minutes? If not, are we pushing lytics in 30?
Section 5. Connect with the Academy. Continue your clinical education.
I'd highly encourage you to hit pause on this explainer right now. Grab your phone and scan these QR codes to connect with Dr. Pharma Academy across all their major channels. Staying sharp on the latest clinical guidelines is a never-ending process, and this is exactly how you keep those skills razor sharp.
All the incredible insights we covered today come directly from the rigorously researched materials by Dr. Ahmed Sabri. He's a board-certified pharmacotherapy specialist, clinical pharmacist, and the actual founder of the Academy. Keeping up with his work is pretty much a surefire way to make sure your bedside practices are always setting the standard.
So, I'm going to leave you with this final, pretty critical question. Think about your own word for a second. Are your facility's ACS protocols truly running on the tight 2025 ticking clock we mapped out today? Or are you unknowingly putting patients at risk by relying on outdated dogma like routine oxygen and blind lytics? Take this knowledge back to your team, tighten up those timelines, and keep saving lives. Thanks so much for learning with me today.